Oh yeah, that would be great. I'd love to see
Really
that.
does. So, yeah. So this is the article which I think you mentioned briefly a few weeks ago. It was published by some of my former colleagues and some of my current colleagues about this variant of interstitial lung disease seen in lupus patients, and they kind of describe these island-like areas of fibrosis, which are very well demarcated, and notably they're involving the corners, specifically the anterior corners of the upper lobes, and then the lung bases, and then on imaging you're seeing this pattern of it kind of looks like honeycombing, but it's very well demarcated and almost looks like cysts in the way that the rest of the lung is really spared adjacent to it, without significant traction. So they didn't have much histopathologic evidence here, just because these patients typically don't get biopsied. But then it seems like the majority of the times it was showing fibrotic NSIP and some honeycombing. So, and this pattern also is seen in other connective tissue diseases, but we have a lot of lupus patients here in Atlanta, so we see this pattern very commonly with lupus.
Yeah, I don't know how much of that is honeycombing, and I'm always wondering how much of that is fibrosis. You know, that was the issue with that paper. There was really no path proof of what this is. I mean, we do see some bizarre patterns with lupus.
Is there any thought there may be some vascular injury, because many of the lupus patients have they get PE or they get antiphospholipid antibody syndrome, which would make it different than, say, the other connective tissue diseases? Because we don't see, I mean, when I don't see a lot of ILD with lupus, it's not that common. And
Exactly.
and my question is this? I mean, clearly there's this sort of discrete these macrocystic areas, but the only thing that would make me wonder why it looks a little different is the vascular component. But I don't know if in their references they had any papers that didn't have biopsies or autopsies. I admit I just kind of read through the pictures and kind of skimmed through it. I haven't had a chance to read it in detail, but I'm curious what your experience has been.
I'm not sure if there's a vascular component. I think that hasn't been really clarified. I mean, as far as what's exactly causing this stuff, I'm not sure at all.
Okay.
Yeah, I say most of the patients with lupus who develop some form of severe fibrosis, NSIP, like, I mean, it can happen, but a lot of them have, under really detailed workup, mixed connective tissue disease. It's not just lupus. But I mean, I've seen this pattern many times in lupus, but again, there's not a ton of volume loss. The airways usually aren't even pulled open. There's very little bronchiectasis. I'm actually curious pathologically what's there. We label everything that's cystic that looks weird fibrosis, but I wonder how much of it is actually fibrotic. I mean, I'm sure there's some there, but
yeah. So on the cases that they described in the paper, they said they've seen a lot of, it's been just histopathologic features of fibrosing NSIP, and then with some organizing pneumonia and some honeycombing, all mixed in. But then the pathologists kind of agree that it doesn't look at all look like UIP, IPF.
exactly.
You know, so it just looks different.
And I think another point there is not everything with honeycombing immediately makes it UIP.
Right.
I mean, you could see pathologists are not realizing you can see quote unquote honeycombing. It also depends on what a pathologist used to describe honeycombing. Is it true a fibroblastic focus around a cystic space? You know, other people just say, oh, there's areas of plugs or interstitial like plugs that look like organizing pneumonia, but they see them in the interstitium and they say, oh, that's a fibroblastic focus. But by definition, pathologically, it has to be adjacent to a honeycombing space. So,
and Peter, in that image you're showing right there too, it's like, is there really much traction bronchiectasis? Because
No.
Those airways don't, yeah, and that's, it's another thing that we often see with these connective tissue disease. And granted, lupus, we don't see it as often as others, but yeah.
Yeah, that's exactly. So I think some of the pathologists have called this honeycombing, but I think they all agreed that that this is not UIP, so that we don't call it UIP really in our pathology.
So do you have some examples to show?
Yeah, so here are some of the cases that I had picked out. And these are cases I think that I personally, let's just say it over the last just the last year, but we have a lot. This is kind of a pretty obvious, pretty well advanced case. So you can see lung bases. You're seeing these kind of cystic changes. There's some reticulation down here, but like you guys are saying, there's not much in the way of traction on these airways which are coming down, or bronchiectasis. And if you go to the upper lobes, again, well demarcated islands of fibrosis here in the anterior upper lobe. So that's
that degree of pulmonary hypertension is pretty unusual for lupus as well, right?
Yeah, I don't remember specifically. Yeah. I mean, there's some person obviously, and then so again, by probably more commonly, what I usually see is the small pleural effusions and pericardial effusions. So serosal disease. This person obviously has severe pericardial disease related to lupus, and this is obviously very bad pulmonary hypertension.
Yeah, I mean, the lupus ones with this often have CTEPH, because we know that that's a thrombotic state.
Yeah.
And I have to say, I mean, I have seen some lupus cases with big PAs and pulmonary hypertension. It's less common than scleroderma. It is associated with, it's actually technically under the PAH category. It's just much less scleroderma, but most of the cases with bad PA, I mean, this is awful, usually have CTEPH. But I don't see, I mean, it's hard to tell from the scan.
Yeah. Well, and I'd also make the comment, Peter, in this case, pulmonary hypertension, at least pulmonary arterial hypertension and connective tissue disease, when they have pericardial effusions, portends a worse prognosis. And I wonder if it's actually a pericardial effusion related to that rather than just like a lupus serositis.
Is that true? PAH with pericardial effusion prognosis? Okay, I didn't know that.
Yeah, I'll
No, I believe I just
didn't. To be honest, I don't remember the pulmonary hypertension details of this patient. I'd saved them from a while ago just for the lung parenchymal findings. But yeah, it's pretty impressive. I kind of overlooked that. Yeah, it's pretty severe. So that's one. This is a much more early. This patient was younger, but you could see. So we see this a lot of the time, and when I see something like this in a younger patient, immediately we think about in Atlanta here. One of the things we think about is lupus. You'd see the ground glass here at the lung bases with some very small cystic changes. You can see some changes here, and then very early changes in the upper lobes anteriorly. There. So I thought that was a good early example. I think this patient was in her early 20s. And then this is a more advanced example again.
Is this pure lupus, or is this lupus combined with some other?
These were SLE cases, lupus.
Not combos.
No.
Yeah, that's kind of what I was wondering, David. This was some overlap.
So we've done them before.
And then
this is an interesting pattern I see a lot with lupus patients. I have to say, this profound paraseptal emphysema, and they're non-smokers. And I've always wondered what the hell this was. No, but it to me, like, and I have cases earlier where it's just along the fissures in the upper lobes, everywhere subpleurally, and it's just, I mean, it looks like emphysema to me.
yeah.
I mean, studying the fissures, I mean, it's pronounced, and I always like, I wish I had a piece of those lungs to know what the hell that is, because it just looks like this one has a little more, maybe some reticulation associated. The airways are a little abnormal here. There's clearly, but this is a pattern I've seen a bunch of lupus. and I never know what to do with it. I never know what it means.
Yeah. And I think I have one more. This is another very mild one. You can see this one doesn't have much in the way of reticulation. It's almost mainly just the cystic changes here.
That one's so strikingly asymmetric too.
Yeah.
That's why I wonder if there's a vascular component to this. But
It's-
why is it digesting the lung and not really scarring it down? I don't know.
Yeah, it's almost like, you know, how you see in people with microvascular disease associated or somewhat probably related to interrupted pulmonary artery. You know, the contralateral lung gets that subpleural cystic change, either from
it's almost like a bronchopulmonary dysplasia, but clearly acquired.
What do you guys think about the possibility of just the serosal, if the patient has chronic serosal inflammation that could chronically cause damage to the lung parenchyma? That's something I thought about.
It's actually very, you know, it's actually a really interesting thought. I've never thought of that, but that it is conspicuously along the pleural surfaces where we know they get inflamed. So that's actually actually a very interesting thought.
I wonder, any of the severe cases ever go to transplant?
I don't know. They may, but I'm not sure.
Because I bet if they did, it would be probably doable to go back and get the explant or piece of it and look at it.
Yeah, it would be really interesting.
We have never, to my knowledge, we've never transplanted a patient with lupus. We've transplanted patients with fibrotic NSIP like scleroderma or pulmonary hypertension scleroderma, but I don't recall one. But I'm sure somewhere someone has, and it would be really, like I said, really fascinating to look at that explant, see what's going on in those holes.
Yeah, that's always puzzling to me.
Cool.
Well, that's all I have.
All right. Well, thanks, Peter. That's interesting. And thanks for having the article up too. All right. Who wants to go next?
I've got a couple.
All right. We'll make you the presenter.
So this fellow came to Harborview, our trauma hospital, after a gunshot wound. You can see the bullet track, and he's got a lot of blood in his left pleural space. And he did go to thoracotomy. I'm not sure exactly what they did, how much resection he had and how much resection he didn't have. But things were okay for a while after the thoracotomy, and then eventually he developed this kind of a strange pattern up here with this kind of bulgy thing here, looking kind of weird. And then here it's looking more and more angry. And this did result in a CT scan, which we called abnormal. There's this consolidation in the left lung, kind of a bird's nest pattern. Looks like kind of like a venous infarct sort of thing. And if we can see some narrowing of the airway approaching this to the upper lung, it seems to terminate about here. And if we go to coronal, you can see that there's also some beaking of the pulmonary artery going to this. So this represents the twist. And this was a left upper lobe torsion here and infarction after the surgery. So I don't know what caused the left upper lobe to rotate like this, but this was verified then at reoperation where they removed this necrotic infarcted left upper lobe. They said it was a 180-degree torsion in a clockwise direction. So left upper lobe torsion following thoracotomy. So this is one of the few cases where I've actually been able to see the beaking and things like that. Most cases that are labeled as torsion are sort of disappointing in the imaging, at least around here. You guys have shown nicer things. So here's another example. This is sent to me from former resident fellow who's now in Hawaii, and this is a left lower lobe torsion, again with that same sort of bird's nest venous infarction look to the lobe. And we can scroll through it here, you can see the sort of twist of the vessels here. I just have very limited imaging on this, but you can see the twisting course of these vessels reflecting the torsion. This was a left lower lobe torsion, and I think I have one more playing for you here from this outside case. So I don't really see the beaking that I'd like to see here, but torsion again following, this was following a thoracotomy as well. So 2 cases of torsion. So
David, do you think the first one may have been caused because a lot of times when they do these traumatic resections, they're not always anatomic or like they would be for like a controlled, say, lobectomy or segmentectomy. Sometimes they, and depending on the surgeon's experience, they just kind of wedge out the devitalized lung. And I've seen some weird anatomy, and I wonder if that something either with the fissures or something set that patient up for a torsion, or when because or maybe something at the hilum. Were you able to tell what was left on the scan?
I'll have to go back to the, I'll have to dig out the op report and find out, you know, what they did and how they, you know, whatever resection they did, how they did it, stuff like that. But I think you're right. I think that sometimes the trauma surgeons are not necessarily, well, they're operating fast for one thing, and they've got to explore lots of different parts. So, so I don't know exactly what happened. Let me check the op report. Maybe I can clarify that. Okay, this fellow has some shortness of breath and cough. He's a cigarette smoker. He's a veteran, I think in his 70s and stuff like that. And he has some findings here. He's got a few little subpleural dots out here, and he's got them on both sides. And those are the sorts of things that we can see. Again, here we've got a couple of those things lurking out here, right on the pleural surfaces. You know, this fellow was exposed to some dust storms in the Palm Springs area of Southern California. So he breathed dust for a few days, and his symptoms seem to have developed after that. And so he's got a variety of these little subpleural dots. He did have a lung biopsy, and there was a question, you know, could this be silicosis? If you've got confluence of these little subpleural dots like that, which represent dust that's carried out in lymphatics to the edges of the lung, you call it pseudoplaque if it starts to conflue. But he did have, he had a lot of foreign material in his lungs, and they classified it as dust. They didn't really think it was silicosis. They thought it was a mixed dust from this blowing desert sand. So he has dust exposure, doesn't, you know, I didn't want to call it silicosis, but he's got a lot of mineral in his lungs.
But isn't it just emphysema? I mean, isn't that what they saw predominantly pathologically, was just a bunch of emphysema?
Yeah, I think they had transbronchial biopsies. I don't think they actually got big pieces of lung that would show them the emphysema. And so they found dust in his lungs, and they found some reaction to the dust. And he also has emphysema. Now, one of the things that was not clarified in the clinical material I have was how much of a smoker he had been. So yeah, he has emphysema, I agree, but he also has dust in his lungs, and that probably is what's causing these little subpleural dots. So this is one of the patterns of silicosis that we see, or co-workers pneumoconiosis, is small subpleural dots. Okay, so that was dust exposure. And, you know, they had sort of billed this case as being exposed to a volcano. It turns out that that fanciful and very hopeful thing that caught my attention did not pan out. There was no volcano exposure, but they wanted it to be the micro silica exposure that people get from breathing volcanic dust. No such luck. And this is a woman who has these ancient chest radiographs from the late 90s showing pleural effusion. She had a variety of presentations with pleural effusion, sometimes one side. In this case, at this time, it's both. She does have this kind of reticular abnormality up here. She's got normal lung volume, and she has lymphangioleiomyomatosis. And this is, maybe I can enlarge these images here for you. She does have some cysts that you can see here in her lung bases. This is scanned CT on film. Some people may remember film. and she has bilateral pleural effusions, which are presumably chylous effusions at this point. So she was transplanted in the year 2000, and she's still being seen. She does have some manifestations of chronic rejection, and interestingly, she has some recurrent cysts in her lung. So she doesn't have very many of them, but you can see some of these things lurking around here. They stand out somewhat better on exploration views. It brings out the density difference a little bit better, but you can see these scattered small cysts. She had a biopsy years ago, and it did disclose recurrent LAM with cysts in her lung. So this is one of the diseases that can recur after transplant LAM. So there are these circulating cells that, it's like a metastatic low-grade tumor. These are circulating in the bloodstream. They end up in the lung, and they can cause these little LAM lesions. So she has recurrent LAM. And I think this was first manifest about 7 or 10 years after transplant. Okay. And then I'd like to show you this this woman here who is 48 and is only 4 feet 5 inches tall, and she has some distinctive facial features, and she has pretty severe aortic stenosis. She had a bicuspid aortic valve, aortic stenosis, and she also has some irregular perfusion of her lung here. So she's got some mosaic attenuation. She didn't really have a workup for airways disease, but she does have some obstructions of pulmonary arteries. You can see this pulmonary artery is starting out into the left lung, and then it just sort of tapers off to nothing. So she has some branch stenoses, and this is all part of a syndrome, which I'm sure you all have heard of, and I have trouble spelling. It's called geleophysic dysplasia. So I expect to have a series of 20 of these cases, and others to have written the definitive articles on this syndrome, but I've never heard of this before. So geleophysic dysplasia, it is associated with valvular stenoses, not just aortic, could be mitral as well. Here's that very thick aortic valve. And it can be associated with branch stenoses in pulmonary arteries, of which she has just a couple of minor examples. She did have pulmonary hypertension, and she got a TAVR, and I don't think she's had any other interventions since then. So is this a familiar condition to anybody? Geleophysic dysplasia. It's mostly a skeletal and a facial syndrome.
Not if it used to, unless it had like an eponym before, like Noonan syndrome or one of these things. I've not heard of that.
Is the short stature because of long bone problems? Her bones don't, I can't see that humerus all the way, but her thoracic cage looked pretty decent.
Yeah. So, and her chest radiograph was not strange looking either. She's small, but she seemed to have normal proportions on her chest radiograph. I haven't looked for long bones in her film record.
It's interesting. It seems like a lot of these skeletal dysplasias are associated with aortic stenosis. I wonder why that is. Or something wrong with the aorta.
Yeah, and then we had a case of shown complex last week, and I'd never heard of this before either. But our pediatric our cardiologist who rotates on our imaging service, who specializes in adult congenital heart disease, he talks a lot about Shone syndrome, SHONE, or Shone complex, and this is these are people who have left-sided stenoses, left-sided obstructions. It includes things like mitral stenosis, aortic stenosis, and coarctation of the aorta. I'd never heard of this condition either, but we have an example from last week of a young woman who has both mitral and aortic valves replaced with Shone complex. Is that a familiar term to you guys?
Yes, that's more familiar.
That one, yeah.
Okay.
Yeah, and it's associated with parachute mitral valve as well and subaortic membranes that contribute to the stenosis.
Yeah, and that's actually why she had her mitral valve replaced, not because it was stenotic, but because I think there was a parachute valve. I'll take that case out and
So,
show it next
so
week.
David, this one here, so this patient you said was only like 4'5".
Yeah.
Any idea how big her annulus of her aorta was? I'm surprised that they were able to get a small enough TAVR valve to go in there, because I'm guessing it's a small annulus.
I'll see if I can get the measurements.
Just curious.
Yeah. Okay, and then I wanted to revise a case that I showed a couple of weeks ago. It was a newborn with what looked like left upper lobe bronchial stenosis. There was a mucus plug and there was hyperlucency in left upper lobe, and also a mediastinal cyst, a subcarinal cyst. So I showed it, and I have subsequently gotten the path. And what I thought was a bronchial atresia in the left upper lobe, the pathologists at Children's Hospital are calling a CPAM type 2. So that was wrong. I mean, it was definitely abnormal, but I wouldn't have called it CPAM. It didn't look that bubbly. And the cyst in the mediastinum, they are classifying as an esophageal duplication cyst, not as a bronchogenic cyst. So the experts disagree with the classic radiology in that case. So I'm sorry, took you guys down the wrong thing. It's only subsequently that I found out how I can get the pathology from outside. So I can show it again if you want the correct diagnoses, but live and learn.
So David, the cyst I get because we can't see the epithelium, and but with the bronchial atresia, I mean, many CPAMs have bronchial atresia in them, and we may not see the CPAM portion depending on how extensive it is and what part it is. And sometimes that hyperinflated lung from the bronchial atresia may actually be the CPAM. But if you go look at many CPAMs carefully, you can find atretic bronchi. And if I remember your case, there was an atretic bronchus.
With a nice mucus plug.
And they may not see that on the biopsy, the resection, because it's probably, I mean, when it's removed, they're probably looking at the parenchyma and not looking at a large airway specimen on a microscope.
Correct. Yeah.
Yeah, I agree with both things. I mean, cyst or cyst, you can't. That's why you just say when they're in that region, foregut duplication, and you got both covered.
Yeah. Okay, guys.
Thanks for the update. All righty. Who wants to go?
I can show some cases.
All right, there you go.
Jeff, I don't have anything this week, so.
Okay, no problem.
So this is a case I saw yesterday, which was interesting. So this was just a morphology pre-op AFib. And you can see that he's got, some flattening of the interventricular septum during systole. The RV is hypertrophied. The RA was also a little big. This thing is just super slow to scroll through. And then when I was looking at the kind of the full field of view from that, I'll just pull up the lungs. So slow, sorry. I noticed that it's lung windows, but you get the gist, where the PAs, if you get down to the kind of the left lower lobe PA, you start seeing some irregular tissue along the edge, and maybe when you scroll down, there's a few kind of distal subsegmental branches that are out. I can tell you the posterior segment, right lower lobe is out, but the amount of disease, at least in terms of, would be atypical for CHF to cause this degree of pulmonary hypertension. Fortunately, we had an old study on the list, and I think it's just dramatic. So also look at the lungs. That's why I had this lung windows. You can see some degree of mosaicism, but not really. Sorry, it's because it was a cardiac study. We just scanned 2/3 of the lung. Some mosaicism, but not too pronounced. And here's the old study, and I'll put these side by side. Let's make sure they're the right ones.
Seth, we're losing the sound.
Oh no, I wasn't talking. I was trying to pull over the study. Can you hear me now with this? Hey, can you guys hear me? Yeah. No.
Yeah.
Yeah.
Okay.
Yeah, we hear you.
So this is him now. Yeah. Previously, so you can see really dramatic chronic thromboembolic disease. And I just want to show, yeah, he still has some pulmonary hypertension, but just look at the dramatic difference in the size of the right heart. And this was just about a year ago, actually. But look at the dramatic decrease in the size of the heart post-op endarterectomy. But that we see a fair amount because we do have some, post-op imaging. The ratio before of the RV to the LV was like easily 2 to 1. Now it's about 1 to 1, still thick. But the thing that really impressed me was the improvement in the mosaicism, because that really shows that you're getting out to some of the more distal vasculature. So if you look previously, you can really see how pronounced this mosaicism was. And on the current study, there's still some degree of that, but it's remarkably better. And you know that these areas of mosaicism are due to reflexive hyperperfusion of areas, the few areas that are actually open. So I just thought that was really, because I've seen the heart changes before. Unfortunately, most of our scans that we acquire post-op are within, a few days or so post-op. And the perfusion changes are really still there immediately post-op. The areas of hyperperfusion are really still there post-op, but a year out, I guess, as those kind of start to change as the distribution of blood flow becomes more homogeneous with the opening of the obstructions. I just thought that was really pretty. I had not seen that before. I mean, again, this vessel is this area here. Anyways, I thought that was cool. Sorry, let me just do. Oop, did I spell something wrong here? Oops, let me get rid of this. Let me get rid of this. All right, let me get rid of it. 1 second. This was something I think we've seen before, but I thought this was a Army recruit who was at Camp Pendleton, young kid, I think around 19, was at Camp Pendleton and had a syncopal event and kind of was brought to and a real kind of was out, and they actually resuscitated him. He didn't need to have he wasn't in VFib or had sudden cardiac death. He just passed out. But you can see dramatic. We don't see a lot of interarterial lefts. We see a lot of interarterial rights because those are pretty much for, some people are symptomatic from them, but the vast majority of those are incidental findings. The interarterial lefts are bad news, and you can see how compressed this vessel is. But the other nice thing is you can really see try to show it here. So we know that the vessel should be surrounded by fat, the coronary arteries, and you can really see that in between what is the abnormal ostium, which is dysplastic, there's all this soft tissue along the coronary here, the proximal left main, and that's all its intramural portion. So it isn't until out here it really gets surrounded by fat. So the intramural portion of this is, at least here to here, which did correlate with, they called it a 15 millimeter intramural portion. So they resected this and they unroofed it. That itself is kind of interesting. The other interesting thing, or kind of one thing I had not seen in a long time, is the fact that he actually had, not the best looking. This is the outside MR. Four chamber shows it better, but he actually had infarct in the left. Let me show the four chamber. It's prettier. He actually had infarct in the left main territory, so not good. So he had that fixed, but we'll see how much. Oh, come on, man. Come on. Let me see if I can get this. No, that's not the right sequence. Here we go. So you can see, obviously I like to look at my delays on the short axis. These look more like single shots. They were done at the outside, but you can see the extensive septal enhancement as we get more to the anterior wall. This is going to be all that LAD territory. There's some circumflex injury. Presumably this is circumflex down here, and the RC, which is all this other stuff, is spared. So pretty profound left main injury. Fortunately, some of this will be viable. I'm hoping that most of this will, or a good chunk of this will recover. But yeah, I mean, I've seen usually the kids that, anyways, good case. And then last, this is interesting. I want to know if any of you guys had seen, we've seen lots of, and it fits, and I think I've seen this before in a few cases with amyloid, but I was wondering, so this patient has gastric amyloid and has all of these cystic areas, and we know we've seen cystic lung disease with amyloid, but these cysts have that kind of bubbly calcification or those kind of profound calcifications, and we've all seen those very heavily calcified nodules with amyloid. I'm just wanting to know if other people have seen cases where you just have the cysts with the robust amyloid or presumed amyloid around edges.
Yeah, the little ossification.
Yeah.
In those,
easily.
yeah.
Because if you look on windows, they're amyloid ossification, calcifications, I'm not even sure what they are. But that's all she had. She didn't have any other nodules, no cysts without those areas, and without those kind of calcified thick nodules or ossified thick nodules. So other people have seen that.
Yeah.
Okay.
Yeah.
Well, sometimes it's a little nodule in the wall and wall of the cyst. It doesn't have to go all the way around it.
Yeah. So yeah, most cases of amyloid, I think of, I have those either robust calcification or those big chunky calcified nodules, or just pure cystic disease. But okay. Yeah, those are my cases.
Cool. All righty. All right, you see a chest radiograph here. So this is an elderly person who presented with shortness of breath and abdominal pain. Don't remember all the details, but you can see the frontal radiograph is very abnormal. There's these bilateral perihilar masses, very discrete, sort of branching from the hyla, almost look like lymph nodes, but a little bit more irregular. And then on the lateral, you see it's flipped backwards, but you can see they're more posterior located than the hilum. So there's some kind of interesting bilateral masses in the lung. And on CT scan, we see these extremely large endobronchial masses. You can superior left lower lobe going down to the basal segments as well, really descending them, and you can see quite large vessels passing around them. There is a big subcarinal lymph node, and we can see out distally there's some plugging of the airways. But endobronchial mass is so bilateral like this, we'd have to think about, and you can see the sort of protrusion, the convexity of it there. So looks neoplastic, and bilateral, you'd favor this being metastases. And renal cell probably is one of the more common, but these aren't particularly hypervascular. And this ended up being, they biopsied these. He had finding in his abdomen that suggested a GI malignancy. And this is all colon adenocarcinoma. And these are probably some of the most exuberant endobronchial metastases I've ever seen, and ones that had a nice radiograph to go with it. So I was just waiting on path confirmation from this case, but yeah.
So do you think most of that is tumor just growing within the airways and expanding, or do you think the tumor is more central and then there's mucus impaction?
I think a lot of it is tumor,
wow.
given how expanded it is. I mean, you don't typically see that much lumpy bumpiness with just like, when you have a mucocele or something. Also, it's pretty much the same attenuation. It's not particularly water attenuation, but I mean, the bronchoscopist only took a chunk of the proximal stuff, but to me, it doesn't look. If you look at the lung windows, that looks more tumor-like. And we see endovascular metastases with renal cell as well. This being, of course, the GI cancer, but those tend to be also lumpy, bumpy because they don't grow evenly. So I suspect that's what this was, all tumor.
Any lymphadenopathy, Jeff?
Just the subcarinal lymph node, not a lot. Just this node right here, which may actually be a lung nodule. It's hard to tell because there's a lymph node there. I think it's actually just a lung nodule. So no, it's just airways, just a weird, I mean, I've seen them before, but they're just not that common with colon, other than colon's common, but I haven't seen it.
It's just kind of interesting how there's that much lung involvement, but it doesn't go back into the lymphatics.
Yeah, I don't have a good explanation for it.
Subcarinal.
Alrighty. This was an let's see, I'm going to do that one next. So I'm curious what you guys think of this. This is something kind of one of these surprising cases. So this is a patient who had a heart transplant about a month before the CT, and he was a ischemic cardiomyopathy, and it was complicated by graft dysfunction. So this is a month out. You can see he's got a renal dialysis catheter. At the time of the surgery, they resected his ascending aorta because there was a dissection flap. So this is a distal anastomosis. So this is a graft. They use the hemishield. I presume that's like a Dacron graft. Then you can see it distally, and then the donor root is still there, and it all looked fine at this time from a transplant standpoint. They were most interested in his lungs for the CT. So fast forward a month later, they scanned him only because they were concerned about this pleural effusion. He was walking around, eating, fairly hemodynamically stable. His trach is out at this point. And this is one of the ones you open up and all of a sudden you see something like this, kind of makes your heart skip a beat or two. I mean, clearly there's this new dense rim around the graft, and it's blood. I was not expecting to see that, and in such a stable patient. And so, I mean, here we are 8 weeks out of transplant. So the so they're not doing anything about this at this point. They're watching it because he's stable. But the presumption was he must have had a delayed, slow oozing leak around the aortic graft. If you look on the coronals, it's confined to just that graft segment right here. And because it looks like an intramural hematoma, but there's no wall. It's just hematoma. So I don't know. Has anyone ever seen? And I can't prove it's blood and not some kind of protein reaction, but it looks like blood. Has anybody ever seen this kind of delayed, whether it's a transplant or not, but sort of periaortic graft leak?
I think that makes sense. I mean, we've seen a lot of times they form small kind of pseudo or contained, like it looks like a little pseudoaneurysm or contained collection, but I think that makes the most sense.
Yeah.
But you guys couldn't give contrast on this?
Well, this was done for his pleural effusion, but he did have a CT angio like a couple days later that didn't show anything. No active bleeding. It just showed it stable. So they're going to watch it.
So Jeff, it wasn't symptomatic per se. The repeat CT was because of pleural effusion. You said?
Yeah. So this was the CT I came across. This one here. It was done. Let me go back to the axial. So yeah, this was done purely because of these pleural effusions, and they weren't sure what was going on in the left lower lobe. And you can see it's clearly just atelectatic. As an aside, you'll notice that left lower lobe is kind of dense. He had been on amiodarone for many years, so I presume there's some, and you can see it on the old one too. There's some iodine deposit in the lung.
You also wonder if he might have had an infection there, that anastomosis, and got dehiscence.
Maybe.
And then that caused.
Yeah, I didn't save the CTA. It didn't show anything new. I can try to pull that down. But yeah, so it was this was the incidental finding I wasn't expecting to see.
Yeah.
But when I called them, they're like, "Oh, he feels fine. His hematocrit's stable. He's been walking, and the only reason he's in the hospital is they're just he's close to discharge, or was
I mean, on that slice, the mediastinum doesn't look too inflamed, right?
No, that's the thing. It's so clean that it almost looks like it's contained by something.
Yeah. That's
And
interesting.
I had to go dig through the op note because I didn't realize at first he had a graft or where the graft was. I saw this here and I wasn't sure what they grafted, but this is exactly what they did. It's a tubular graft, donor native proximal aorta root. So there's that proximal anastomosis, and then here's the distal. Maybe, yes, so there's not even like a felt pledget or anything in there. So I don't know. Okay.
Did you give contrast to show that that's actually blood and not just proteinaceous stuff?
They did.
I mean, I
there's
agree.
a
It
contrast
looks
study
dense.
later that showed it's blood. So
Okay. Yeah, because occasionally you just get those sterile perigraft fluid collections, but yeah, they wouldn't.
Yeah.
I mean, I agree. That's too dense.
Right, it's really dense. All right. Speaking of heart transplants, this is kind of a fun case, something you probably won't see very often. So this is a young man, and I believe I actually showed his pre-transplant CT. I want to say back a while ago. He was transferred here for acute PE and asthma a long time ago, but we looked at his imaging and determined he had CTEPH, really bad CTEPH, like with cor pulmonale. I don't have his pre-op imaging merged in here yet, but I believe I showed it. Anyway, really bad CTEPH. We were going to try to get him to San Diego, but he was too sick. So we did a transplant here. We actually did an en-bloc heart-lung, which we have not done in, oh boy, 15, 20 years. But he's got an interesting looking radiograph. He's got this very narrow mediastinum and a funny orientation of his heart. And if you look on the lateral, clearly looks like almost an absent pericardium or partially absent pericardium. And this was his CT. And what's kind of cool is something, because we don't see this, because we don't do en-bloc transplants, is that you can see the airway anastomosis is actually at the trachea. And then they've got there's the aortic anastomosis, but his heart kind of floats in space like this. There's the anterior junction line. And I'm not sure, I guess, I presume there's some missing pericardium in here. I mean, you can see, you don't really see much of it. There's a little bit down here, but not really. So it's just kind of floating out there in this funny orientation. But this is both donor heart and donor lungs. So it's a tracheal anastomosis right there, and then the vascular connections. I don't know, does anyone, I mean, David, you've probably seen some of these in the past.
I've not seen that many heart lungs, so I'm trying to figure. He doesn't really have the usual anterior junction line because he doesn't have parietal pleura. Normally the anterior junction line is 4 layers of pleura. He only has 2, and he also probably doesn't have his sternopericardial ligaments intact. So that's why this heart is flopping around.
Yeah.
So yeah,
that's what caught my attention on this case, was just the unusual orientation of the heart and then this tracheal anastomosis. And then light bulbs went off and I remembered it was who it was, and I went back and was able, when I saw his preoperative imaging, I knew that this was the same guy. But
that's
yeah, he's doing well from a clinical standpoint. But we just, the heart lungs don't do them anymore. For the pulmonary hypertension, they typically do lung transplants but this one, his right ventricle was too far gone that a lung transplant, when he didn't have anything left, that wouldn't have made a difference. But yeah, I didn't realize they did them en bloc like that, but it makes sense. You have fewer anastomoses and you just take it all in one big chunk.
We do a fair amount for congenital heart diseases.
Oh, do you? Oh, good. Okay.
Yeah, this is not,
All right, and then this last case was another one that was quite of a challenging case. I want to get the timing right. There's that one. So this patient was also transferred to us, and at the time, I should show was transferred to us with massive hemoptysis that had then stopped, and a diagnosis of a left lower lobe mass. And so this is the CT that came with the patient. And you can see the patient has a lot of atherosclerosis and a descending aortic aneurysm, and there's this funny little outpouching right here that's associated with this alleged mass. And so this was billed as a lung cancer that was invading the aorta, and I didn't quite buy that diagnosis. No one had biopsied it, which may have been a good thing. But looking at this, this really looked like to me more of something's wrong with the aorta, and that had eroded into the lung. You see this displaced pulmonary vein right next to it here, and then the airway being sort of deflected. There's a little bit of aerated lung. And then this mass just kind of goes right up against the aorta, and there's this irregularity. Luckily, we were able to find out he had old imaging, and they were able to get it pushed to us electronically rather quickly. So this is about 3 months earlier. And you can see that that so-called mass was much smaller, and at this point really looks like it's part of the aorta. But it was on the outside, it was called a mass, so they did an entire workup with a PET CT that showed only minor metabolic activity there, which, so for something to change that fast and have not that much FDG uptake, I don't buy it that it's a cancer. So they ended up doing an MR, and I've got some of the images here. Here's the post-GAD arterial phase. They did the whole thing, but you can see, and let's see if we can get up higher. Right there, you can see sort of this. It looks like it's in continuity with the adventitia there of the aorta, which I think is pretty convincing. But and then there's that little beak of it right there. So this is presumably a pseudoaneurysm or a contained rupture, ulceration, whatever you want to call it. I don't know the right terminology for it, but they ended up treating it with a stent graft. I can't remember if I saved those images or not. Probably. Oh yeah, I did. They just put a nice big stent graft across it. And fixed the abdominal aneurysm while they were at it. Treated it as it didn't seem to be infected, but treated it as like a contained pseudoaneurysm / ulceration / perforation. But probably it's a good thing to always question things that look funny, and it would explain the hemoptysis. But also it was a good thing they didn't try to biopsy this thing. That may not have gone well. But I haven't seen this very often that I can recall, maybe one other time where something had eroded into the lung.
That looks like a ruptured aorta to me, Jeff.
Yeah.
With that, yeah, on the left side. And what's going on in the lung?
Yeah, that's all the blood. I mean,
yeah,
clearly leaked. Yeah, I mean, they presented with hemoptysis, and it was thought again it was billed as a lung mass causing hemoptysis, which just didn't fit. Didn't look like it. So we went down the aortic route.
Can I share something real quick on like a sign related to that I recently learned about?
Absolutely. Let me see what I got to do. I think I hit that and then make you the presenter.
Okay. So I recently learned about this sign from one of my colleagues that had heard about it, or I hadn't officially. I mean, it makes a lot of sense, but thrombus. One of our new attendings who trained at Mallinckrodt told me about this sign, but thrombus fissuration sign. So it's basically an acute.
Can you make that bigger at all?
Yeah. It's like a. So if you have a partially thrombosed aneurysm and acute angled kind of fissure going into the thrombus is a sign of impending rupture.
So that's just that the thrombus is breaking down and that there's now blood flowing into it that's about ready to disrupt it. Is that the
exactly? Yeah.
Oh, that's cool.
It makes sense. I just never really. This was published somewhere.
Thrombus fissure.
Impending rupture.
Makes a lot of sense.
Yeah.
Yeah. That initial one that you showed, I think, was a contained rupture, basically.
Okay. Yeah.
Around it.
Yeah, and the MR showed the adventitia out there, but clearly it was not a lung mass invading. Even on the CT, I think it was pretty convincing. But it was nice being able to get the old imaging within just less than half an hour.
Can you go back to your imaging? I want to see if it had that acute.
Absolutely. Yeah, so this is when the patient presented.
Like on that image, you see that, like how it's acutely pointing into the.
Yeah, that's what bothered. That's what I didn't like. I mean, to me,
Yeah.
this is not normal.
And I think there was something like that on the prior imaging too. It was like a acute. I kind of caught my eye.
Yep, right there.
Some pointy. Yeah.
Yeah, interesting. That was 3 months earlier.
Yeah.
So it was probably just slowly, and even there, it looks like it already got into the lung.
Yeah. So I knew about this about the impending rupture sign on non-cons, where it was the hyperdense crescent sign.
Uh-huh.
But this is a different one for contrast, which I recently learned about.
Well, that's cool. Thanks for sharing that. Keep an eye out for that. Yeah, these aortic cases, I mean, of course, I saw these two on the same day, and they can take a lot of time, or at least cause a lot of confusion. They can be really challenging, especially when you have a lot of atherosclerotic disease, sorting out what's thrombus, what's plaque. I mean, here, the other thing that I also favored, let me go back to the newer scan, that this was aortic, was just the fact that you have all of this plaque going all the way around. It's patchy, but you can, as you scroll through it, it's pretty much there.
Yeah.
Yet there's nothing here, which
Right.
if there's an intact wall, you'd expect to see some clot. I mean, some
Yeah.
clot. You don't. So, and then this little beak right there points to like this being aorta. So
Yeah.
cool. Well, thanks for that. That's helpful. All right. Well, it is the hour, so great cases as usual. And Howard said he'll be back next week. So everyone have a good rest of your week and a good week.
Thank
Thanks,
you.
Jeff.
All right.
Thanks, guys.